So this is a right revision tympanoplasty. You can see that, so this is 12 o'clock, 3 o'clock, 6 and 9. And transcanal approach, we see this prosthesis, which is a titanium prosthesis, which is partially dislocated. You see there is no much contact between the cartilage which was interposed during the previous operation and the prosthesis head. There is no malleus, so I probably have to insert a malleus replacement prosthesis plus a TORP in this case. First I need to remove this previous prosthesis. What I'm going to do now, I will dissect the prosthesis head. Calmez du marteau. This patient has been operated 2 times before, and it seems that she never experienced any improvement post-op. So I try to dissect this fibrous tissue here anterior to this prosthesis. Ciseaux, s'il vous plaît. Okay, now the head is already dissected, free from the tympanic membrane, and now I need to dissect the shaft. 3 de chouk. Because I don't even know what the status of the footplate, if there is any fixation or... Oh, you see here, this is a partial prosthesis. You see this wire hat, which usually is placed over the stapes head. Tête en déclive encore, s'il vous plaît. Stop. All right. Calmez, s'il vous plaît. So the plan, of course, is to remove this this prosthesis over the stapes head. So I need to dissect, but there's a lot of fibrous tissue all around, so I don't see the stapes itself at the moment. So I have to see where the fascia nerve is. The fascia nerve is there. It's pretty close to this connection here. And the difficulty that we have here is to remove this prosthesis at the moment, because there's some bone here also, and of course I don't want to pull the prosthesis immediately because there's a risk of pulling the stapes also with that. So we need to push a little bit part of this attachment to the stapes, but it's really strongly attached. Can't do anything at the moment. There's some bone here. Okay, that's fine now. I think I can remove it. 3 de chouk. Yeah. There we go. So now I need to dissect the oval window. There is some remnant of stapes, but not working well. Calmez, s'il vous plaît. I also have a lot of fibrous tissue which is there over the promontory. Okay, now it's fine. All right, so let me see what we have. I don't know yet. Can you see the tape? Je peux avoir le dossier s'il vous plaît là? There's some remnant of stapes for sure. This is some kind of anterior cruce here. Scannez s'il vous plaît. So of course you see I don't have any more ossicles here. So we had a really atrophic tympanic membrane, which was of course due to the history of chronic otitis and also history of the previous surgeries. But sometimes you can find a remnant of malleus. I can feel something anteriorly. The CT scan was not very efficient in terms of diagnosis. Table en avant s'il vous plaît. Stop. Calmez, mangez marteau. There's something there, but I'm not sure whether this is any residual ossicle. Looks like we have some malleus there. Yes, I think so. It's a remnant, and it's not a completely normal malleus, but that's fine. I can use this. It's long enough. So of course I may have to take a perichondrium graft or maybe a cartilage. You see the malleus, which is really anterior, so it's always very interesting to take it back in order to use it. You have some tympanosclerosis also here. You can see lots of plaque all around. Ciseaux. Calmez. Alright, now I think I can relocate the malleus. I need to cut the tympanic tendon. Okay, fine. And now I need enserrer direct, s'il vous plaît. I will try now to cut the tympanic tendon. There we go. And now I can relocate the malleus posteriorly in order to place it over the stapes remnant. Pince, s'il vous plaît. Okay, now let me check now the tympanic membrane. Maybe I have to reinforce it. Plahon d'abord, s'il vous plaît. We may have some tear now. Not sure, but I need to check. No, looks fine. There's no tear, so it's fine. Okay, good. On va préparer une lame de silastique au fond de caisse. You see all this adherence to the promontory and the middle ear cleft, which means that I will have to put a silastic sheet in the middle. ciseaux, s'il vous plaît. Ciseaux. Merci. Plat rond. All right. Now, the problem that I have is to determine exactly what kind of reconstruction I will be able to do, because the problem is that we have some remnant, as you saw over the over the footplate, but I don't have access to the footplate yet, so it's very complicated. And the problem is that we have also some partially eroded stapes head, and œuf peut-être, and it's going to be difficult to reattach any prosthesis there to the stapes. So of course the best for me would be to have access to the full plate at some point, but you see it's very narrow here. You see the promontory is there. You see the anterior crus. Oh, the fascia nerve is right here. So I need to be in contact with the stapes, away from the fascia nerve, using a needle for that. Bon, tape vers moi. Tape vers moi. Stop. I need to see if I can find any gap at one point to insert prosthesis shaft between the promontory and the stapes. You have some bone here. Pretty tricky, eh? Making a decision is a problem here. Let's see if I can find a gap maybe here to have access to the footplate. Yes, maybe I can find some gap here. You see what I mean here? I have to understand something, because I don't really identify the footplate yet, but I need to see if I have access to the round window niche and see if I have any round window sign here at the moment. Curette, s'il vous plaît. I need to remove the piece of bone here to expose better the round window niche. There we go. Now it's fine. And now I can have access to the round window. You see the light on the round window? Can we? Here we go here. So let's see. I'm sure it's working, yeah, but I don't see anything at the moment. It's strange. Yeah, but the membrane is deeper. Now we can see the better light. Yeah, now it's working. I see the light. Okay? Okay, so I know that the footplate is mobile. Okay, so the only thing I need is to find a gap. We're working on that. Un œuf, s'il vous plaît. There's no gap between the promontory and the superstructure. The only gap is there. And I think it's going to work. I don't think I can use the Silastic band. I can try, but I'm not sure. We have, the problem that we have is a abnormal shape now of the stapes due to tympanosclerosis also. There's a huge amount of tympanosclerosis everywhere. But this is the gap that I like to have to place the distal tip of the shaft of the TORP. So I'm going to use a TORP. And the good thing here is that you can see Trois de Chouc, the stape is bent posteriorly, you know what I mean? And so even if I wanted to use a partial prosthesis, The problem is that then the prosthesis will be bent posteriorly. This is now a good access to this part of the footplate here, and I make a kind of a chamber to leave room for the distal tip of the shoe of the prosthesis. You know what I mean? Yes, but I'm making a gap here, and now I have access to the footplate, I think. Yeah, I'm making a chamber, okay? And now I think it's fine. So let's now measure the distance from malleus to footplate. Crochet out, s'il vous plaît. It's also bleeding at the same time, so but this is due to the pathology itself and the mucosa, of course, which is inflammatory. Okay, so let's place the malleus over this part of a footplate like this. So this is the good position. I need to reposition the tympanomeatal flap first to be sure that the malleus will be in contact with the tympanic membrane when I measure. 1,12, s'il vous plaît. Okay, I think this is the right position of the malleus. I need to lateralize a little bit more, like this. Mesureur. And now I can measure. So I will go into the gap that I was creating here, into the chamber, and using this elongated stay-based measuring rod. And we are in front of the second notch, which means 6, which means I'm going to use a 6.5 millimeter long torp. Okay? All right. Okay, good. Let's try. So 6.5 means 5.5 first. To get 6.5 by pulling the prosthesis back. I'm going to cut the proximal part of the shaft now. Okay, good. And now I will pull back at 6.5, which is the case now. Okay, you can 6.5 now. Okay. All right. Pince, s'il vous plaît. So I will try to use the silastic band, but I'm not sure we can use it, but we can try. Un 9, s'il vous plaît. Un 9, oui. D'abord un 12, pardon. D'abord un 12 et ensuite un 9. So I need to remove this blood and expose again the footplate. This is the place where I have to insert the distal tip of the shaft. Okay? This is the place. Okay, I will push. It's good. I think the length is good, but I need to push to place the silastic band a little bit lower. Pince encore. Okay, I'm gonna try like this. Inspiration encore. So my opinion is that as soon as you have any residual ossicle, it's always better to try to use it to stabilize the prosthesis, especially the malleus, which is of major importance, I think. So this is, I think it is good. And now let's see if I can insert the malleus within the groove. Par rond d'abord, s'il vous plaît. Crochet os. Cannelé. So now it fits nicely, I think. So this is good enough, but I would try to place the band a little bit around the stapes. But it's again, it's not going to be easy because it's really the stapes is really bent posteriorly. Donnez-moi le 3 de chouk. I don't know if I can do it. Yeah, a little bit like this, it helps. Okay? Now you see it working fine. You can see the light of the round window on the right. Cannelé. Yeah, you see the movement. So it's fine. And now I need to reposition the flap. That's an important time. Can you mange du marteau? Because this is the place where the time where I have to determine if the length is not too long. Looks fine, I think the tension is fine. Ciseaux. So I need to check again. I will re-elevate the flap to see if it's fine. But the tension looks fine. We can see the bulging of this prosthesis. And this part of the tympanic membrane is a little bit translucent, so we can see the prosthesis head here. And it stays in place. You see the vertical position, which looks good. Non, c'est pas la peine. Okay, I think it's fine. We're going to stay like this. Okay? Good. All the skin is not that good too. I need to. This is why I took some time to be sure that I will replacing the the skin correctly. But it is very atrophic. But I think it's fine now. Okay, allons-y. All right, it's done. So I will put the mirror cell again, as usual. Hein? Le quoi? Je sais pas ce que. So I didn't put any silastic sheet in the middle. I don't need it because of the prosthesis, which was pulling the tympanic membrane up, lateralizing the tympanic membrane adhesive. So there's much less risk of readherence to the middle ear cleft. It's only when we have a short distance that I think it's better to place it. But now it's fine. All right, thanks very much. I think it was an interesting case. Quite tricky for